Multitraction point strategy endoscopic submucosal dissection in managing difficult colorectal lesions. Colorectal endoscopic submucosal dissection enable en bloc and RZ resection with complete histopathological evaluation. Traction-assisted ESD improves resection outcomes and reduces adverse events compared to conventional ESD. While a single-point traction can facilitate dissection, it may be inadequate for a large or difficult-to-access colorectal lesions. We present a series of ESD procedures for large colorectal lesions utilizing a multi-traction point strategy. MTB entails placement of more than one traction at the different traction points for a sustained and optimal access to submucosa that allows for complete ESD without deep mural injury. This is an illustration how the technique works. First, choosing a correct traction point at the lesion site. And placement of traction at each point should be completed before moving to the second point. And careful attention should be made for the contralateral wall clips. This can be placed immediately on the contralateral wall, distal towards the anal side, or proximal towards the oral side. Therefore, 3 key points should be considered. Choosing the correct traction points, applying first traction before moving to the subsequent one, and clip direction on the contralateral side based on lesion morphology and location. Case 1 is a 73-year-old female referred for colonoscopy with ESD for large LSD granular JNET 2A. Lesion location was ascending colon extending into the cecum. Polyp size was 4.5 cm. No previous biopsies. Conventional bucket creation methods were not feasible due to lesion location and risk of deep mural injury. Therefore, MTB technique was applied. Lesion was examined carefully and limited access on retroflexion view. Therefore, we proceeded with circumferential injection and incision. The lesion was completely perpendicular to the scope, and the muscle was immediately seen on the submucosal dissection plane, which increases risk of muscle injury. We then placed 2 rubber band traction on the anal side of the lesion, strategically choosing the point by which, after applying the traction, this would allow us to access the submucosa. Submucosa was better exposed after traction, and therefore we started a submucosal dissection initially at the highest traction or tension point. This will allow us to sequentially open the submucosal plane and safely complete the submucosal dissection. Submucosal trimming, the submucosal space was widely open, allowing us to complete the submucosal dissection using CO2 or underwater to control the level of the tension. And after completing the dissection, the mucosal defect was examined carefully without any signs of deep mural injury. For closure of this large mucosal defect, we prefer to use through the scope suturing devices, which is our institutional practice for these large mucosal defects. However, clip closure can also be considered, as the main goal is to approximate the mucosal edges to each other. We used a zigzag method when applying each helix, and that allows for closure of the maximum part of the mucosal defect. And finally, we use the cinching device, and complete closure is seen here. Removal of traction point can be achieved using a grasping forceps by removing the contralateral clip each one alone and then dragging the lesion, or by using scissors to cut the rubber band in one traction point and pull up the lesion with grasping forceps, grabbing the second clip. Case number 2 is for a 51-year-old male with large LSDG. Lesion location was proximal ascending colon, and the polyp size was 8 cm. Previous biopsy showed tubulovillous adenoma. Both conventional and bucket methods were not possible due to lesion location and risk of deep mural injury. Therefore, MTB strategy was applied. Closure is similar to previous case, and lesion removal was achieved using scissor to cut one traction band and grasper to detach the second traction and for specimen extraction. Scope access was favorable, however limited access on retroflexion view. We then proceeded with doing a circumferential injection followed by circumferential incision, which allow us to access the submucosa for further trimming and then assess the accessibility to the submucosa. The lesion was found, however, completely perpendicular to the scope. We then proceeded by placement of multi-point traction device using a rubber band on the anal side of the lesion to allow us to access the submucosa. We proceeded with the same strategy by trimming the highest tension point at the level of the traction, and this will allow us sequentially and safely to access the submucosa. Once the submucosa is exposed, we then can proceed with sequential submucosal dissection and then periodic re-evaluation to the submucosal planes. Further into submucosal dissection using CO2, the multi-point traction still effective in exposing the submucosa, allowing us to further dissect and complete the submucosal dissection. Mucosal defect was examined without any signs of deep mural injury. Third case for a 56-year-old male with a large LSD granular J2B with dominant nodule located in proximal ascending colon extending to the cecum and measures 6 cm. There is a previous biopsy of tubulovillous adenoma, and both conventional and bucket were not feasible, therefore MTB technique was performed. Closure and specimen removal were similar to case number 2. The lesion was accessible, however, limited access on the retroflexion view. We then proceeded by submucosal lifting, followed by complete circumferential incision. Access to submucosa was not favorable with perpendicular view to musculus propria, increasing risk of deep mural injury. We then proceeded to multi-point traction strategy, placing the rubber band on the anal side of the lesion and the clips on the contralateral side, pushing them to the oral side so that we expose the submucosa. Same strategy applied by releasing the highest tension point at the level of the traction to allow us to access the submucosa safely. With further dissection, the lesion is being pulled by the traction towards the oral side, exposing even further the submucosa, allowing for continued submucosal dissection very safely. The traction remained very effective up until the end of dissection, and mucosal defect was without any deep mural injury. In conclusion, lesion morphology and location can make ESD technically challenging, particularly when other techniques yield suboptimal access to submucosal plane. MTP strategy offers a safe and effective alternative. However, attention should be made when choosing traction points to optimize exposure without compromising the dissection plane. Proper placement of the clip on the contralateral wall is equally important, and careful assessment of the site, whether proximal or distal, based on anatomical consideration, should be performed prior to deployment. Large prospective studies are needed to validate MTB outcomes in colorectal ESD.